Thank you, everybody, for being here today. We had a wonderful first week of the Newborn Screening Bootcamp, and we're really excited to be back here for the second week of the Newborn Screening Bootcamp. And in the interest of time, because we do have a full schedule for today, I will get started, and I'm excited for what we have in store for us today. I do want to say, first and foremost, thank you to our sponsors who make all of this possible. So here is our agenda for today. As you can see from the agenda, we're talking about data today. So we're going to start with Dr. Amy Brower, who is the Associate Project Director from Mbs Trn within the American College of Medical Genetics and Genomics, which we are very excited for her to talk to us about the collection of newborn screening data. Following that, we have a wonderful panel who I'll introduce in more depth when we get to the panel about how to collect and utilize data to improve racial diversity within newborn screening. And again, very excited for today's conversations, and we're looking forward to hearing from all of you. I want to quickly introduce Dr. Amy Brower. Dr. Amy Brower is a medical geneticist at the American College of Medical Genetics and Genomics and is co-principal investigator of Mbs Trn. Dr. Brower directs a team that develops informatics platforms, resources, and tools to collect and analyze and visualize the shared longitudinal clinical and genomic research data to better understand the genetic disease across the lifespan. And Dr. Brower will go into additional detail about that. I also want to highlight that Dr. Brower serves on several national foundation advisory boards and was the inaugural member of the Secretary's Advisory Committee on Heritable Disorders in Newborns and Children. Dr. Brower, thank you much for joining us today. And if you want to get started, we can get going.
Great. Thanks, everybody, for the opportunity to contribute to this panel and present an overview of the collection of newborn screening data and our efforts at Mbs Trn to help facilitate these data collections. I'm going to start today with a brief overview of Mbs Trn, followed by a discussion of why the newborn screening system that provides the opportunity to identify at-risk infants in a population, regardless of race, income, or location of birth, is the ideal system to leverage data collection efforts to help us all assess, improve, and advance newborn screening. Next slide. Here are my session objectives. Next slide. So the Eunice Kennedy Shriver National Institute of Child Health and Human Development Hunter Kelly Newborn Screening Research Program was created to support investigations and innovations in newborn screening. Their recent efforts have explored the use of genomics in the neonatal period, conducted prospective pilots of conditions that are candidates for nationwide screening to evaluate clinical benefit, and development of novel screening technologies for candidate conditions. Next slide. The American College of Medical Genetics and Genomics plays a key role in these efforts by leading the Newborn Screening Translational Research Network. This is a key component of the Hunter Kelly Newborn Screening Research Program that began in 2008. Over the last decade, we've now matured into a dynamic and committed network comprised of researchers, healthcare professionals, state newborn screening programs, and advocacy groups. Next slide. So we think the neonatal screening of almost 4 million newborns each year in the United States, leading to the diagnosis of approximately 13,000 infants with a genetic condition that usually requires referral to clinical care and in most cases lifelong management, that this unselected cohort of newborns reflects the racial, geographic, economic, and education diversity of our nation, and in fact may be the perfect cohort to help advance disease understanding through data collection, because although every newborn receives essentially the same screen, other factors vary, including treatment choice and the course of disease. In addition, many of the screen conditions have comorbidities, including intellectual disabilities, and these children receive a variety of interventions that could be tracked and analyzed to identify critical periods of development and intervention. Because the newborn screening system in the United States effectively screens over 99% of newborns, it has the potential to provide a unique platform for understanding rare disease and lifelong outcomes. In fact, the process of neonatal screening, followed by coordinated transition to clinical care, helps to facilitate the collection of health information beginning just hours after birth. And because the majority of newborn screening conditions require lifelong care and management, we now have the opportunity to conduct prospective, longitudinal natural history studies on a population basis with unbiased ascertainment. Next slide. Because expansion of screening panels usually begins with a recommendation to screen based on the recommended uniform panel nomination, the steps involved in a RUS nomination and the evidence review helps inform our efforts in data collection and newborn screening expansion. Key to these are considering the net benefit, feasibility, and readiness to all of these efforts. Next slide. A review of the developments over the last 60 years helps us all to quantify the increase in the number and diversity of conditions, interventions, screening technologies, and the clinical care teams and specialists that are involved in caring for these newborns. We can look at each of these areas to identify and assess potential sources of data that will help inform our efforts. Next slide. In addition to these advances and changes to newborn screening over the last 6 decades, reviewing the key components of newborn screening helps to identify stakeholders and points of communication and data collection that could be helpful to learn more about the policies and practices of newborn screening, as well as a location of data points to help inform surveillance and outcome measurements. Next slide. This graphic summarizes the key components of newborn screening and newborn screening expansion. And this image lists some of the characteristics of each component of newborn screening and helps us as we think about the potential to identify and use the data that's collected as part of screening, diagnosis, care, and management. Next slide. 35 core conditions are included in the recommended uniform panel, and it may be helpful to begin to chart the journeys and experiences of affected newborns and their families. As we look across just 3 of these RUS conditions, we can begin to identify some common points of data collection and analysis. Next slide. Newborn screening programs play a key and critical role in newborn screening practice and expansion by participating in research pilots and other efforts, and also by providing access to residual samples. There's now a renewed focus on identifying not just the samples and policies and findings of newborn screening programs, but also the data that these programs collect. These data points could help provide national and state level views of data, both on policies and procedures of interest to researchers, clinicians, families, and advocacy groups, and our federal partners. Our federal partners have played a critical role as we begin to consider data collection and analysis in funding diverse efforts and helping to harmonize data collection, sharing, and reporting. Next slide. Data collection in newborn screening is robust and diverse and covers the spectrum from state newborn screening program information to the Association of Public Health Laboratories New Steps program to ACMG's Mbs Trn effort, and then moving into the very valuable patient registries that are often focused on a single disorder or a group of disorders, and then moving into local, state, and national-based surveillance efforts. We think that we can learn from all of these diverse data collection efforts and identify some key points that could help inform activities. Next slide. So at Mbs Trn, we've developed the Longitudinal Pediatric Data Resource, and this helps us establish a common data model and provide a secure environment for researchers to collect, aggregate, analyze, and share phenotypic and genomic data. We can also think about utilizing some of the standards that have been developed by the Secretary's Advisory Committee's Long-Term Follow-Up and Treatment Subcommittee as they identify some of the key parameters that we should all think about when we're collecting longitudinal data. Next slide. The potential of the newborn screening system to provide case level, local, state, national, and even worldwide data dashboards could help guide improvements across all of the lifespan of newborns that are identified with a condition through newborn screening. This illustration is just a glimpse into the potential journey of individual newborns and helps guide our efforts as we begin to list out the stakeholders, the location of data, the types of data collection and sharing principles that are already included and that we could potentially leverage. Next slide. So if our vision is to create a series of dashboards with permission-based access across from the individual patient level through local reporting, state-based visualizations, and then national reporting and even worldwide, we think that we can leverage the best in the practices and policies of newborn screening programs, beginning with research through implementation, all the way to population-based screening. Next slide. So based on all of those efforts, we've recently launched a new website at Mds Trn and expanded some of the tools and resources that are currently available. Next slide. The first one is the newborn screening virtual repository of state subjects and samples. Next slide. The MBS VR was designed to give users insight into the number of conditions that are screened in each state and territory, estimate the number of expected cases, and provide links to important information about each of the conditions that are part of or being piloted to include in newborn screening programs. Next slide. Prior to 2002, the number of screen conditions varied across the states, and there's been many efforts to harmonize the number of conditions across the states. Next slide. So to help stakeholders understand the conditions that are either currently part of routine screening or could be part of routine newborn screening, we created the Mbs Conditions Resource. Next slide. The Mbs Conditions Resource is sort of a one-stop shop to understand more about each individual disorder and to provide links out to the latest information on each of these conditions, whether it's information about a clinical trial or an advocacy group effort or an ongoing data collection effort. Next slide. You can click one more time. So again, I mentioned the Longitudinal Pediatric Data Resource, and that's been used by many different efforts. You can click again across the United States. And so the goal is to provide a mechanism to collect longitudinal data, whether you're asking a research question or building a public health program. We want the LPDR to be able to support your efforts. Next slide. Next slide. And so please follow the Mds Trn. We are reaching out to the community in a variety of different ways, and we invite your advice and your involvement in all of our activities to help accelerate discoveries and newborn screening. Next slide. Thank you to the organizers today to allowing me to present a little bit, and I'll be excited to hear the next speakers and then around for the question and answer session. Thank you so much.
Thank you so much, Dr. Brower, for such a wonderful presentation. There is one question in the chat box that I want to pose to you. So the question is, Amy, on your screen for the NBR, what does it mean when states are reporting unknown in participating research from the screen?
I'm not sure, Terry, which one you're asking about, but if you email me, I'll make sure I follow up on it, or if you want to clarify that. And then to gain access to the Mds Trn, you can visit mbstrn.org. Some of our tools do require registration. So if you want to access the LPDR, click on the buttons that are strategically placed across the website that say sign up.
Great.
Oh, sorry. And Terry, one thing we're presenting on the MBS VR is we're starting a tool that tells you about the practices and policies of each state that impact research. And so right now, there's a question about, do states consent for research? And so if we don't know whether or not they consent for research, it's currently marked as unknown. But one of our teammates, Dr. Jennifer Taylor, is thinking through that tool a little bit more, and we'll have a more nuanced approach to reporting the role that states' newborn screening programs can play in research.
Great. Thank you so much for such a wonderful presentation. I do want to move on to our panel. If I can hit the slides again. Wonderful. And so for our panel, we're going to discuss how to collect and utilize data to improve racial diversity within newborn screening. And so this, we were excited for such a wonderful panel to dive into this issue and see how we can improve in this area. So newborn screening is often referred to as one of the most equitable public health programs in the country, which it is, but there is still obviously room for improvement. And oftentimes you will still see racial diversity issues within newborn screening. For instance, within the Cystic Fibrosis Foundation, you see delayed diagnosis in Black populations as opposed to white populations. And so there's still an area that we can continue to improve. We want to make sure we're having this conversation rooted in an area that we can actually make improvement. And so ensure the fact that we're not just talking about high level issues, but actually talking about ways that we can continue to move forward. And so while I recognize we will probably come out of today's sessions with just as many questions as we come into today's session with, we are hoping that at the very minimum, we can actually start to have the conversation and talk about some real feasible options on how to improve within newborn screening. And that led us to invite these wonderful panelists who I'm very excited to introduce today. And so I will start with Dr. Mary Schroth, the Chief Medical Officer at Cure SMA. Dr. Schroth leads the SMA Care Center Network and SMA Clinical Data Registry. She's an advocate for people living with SMA and is working with state public health labs and healthcare professionals to support SMA and newborn screening implementation across the U.S. In addition, we are joined today by Dr. Melissa Wasserstein. Dr. Wasserstein is the Chief of the Division of Pediatric and Genetic Medicine at the Children's Hospital at Montefiore and Professor of Pediatrics and Genetics at the Albert Einstein College of Medicine. Her research activities focus on expanding and enhancing newborn screening to optimize the outcome of infants with rare disorders, implementing genomic diagnostics in diverse populations, and studying the natural history and treatment of acid sphingomyelinase deficiency. She's also the principal investigator of Screen Plus. Lastly, we are joined by Ms. Sarah White. She is the Executive Director of the Multi-Regional Clinical Trials Center of Brigham and Women's Hospital in Harvard, or the MRCT Center. The MRCT Center is a research and policy center created to address the conduct, oversight, and ethics of the regulatory environment of clinical trials with a focus on emerging economies. Sarah is an expert in quality assurance and quality improvement of clinical research and has led the development and centralized support of clinical trial registration and disclosure of programs at large academic institutions. Sarah is the co-chair of the National Clinical Trials Registration and Results Reporting Task Force, a large consortium of academic medical centers, hospitals, universities that identify best practices, develop tools, and serve as a communication forum associated with the requirements for clinical trial registration and results reporting that affect U.S. academic health centers. Now that I have read off these wonderful bios, I will make sure to stop sharing my screen so we can see everybody, and they should all be pinned, and so everybody should be able to see all four of us speaking today. And again, thank you so much for joining us. I'm going to start, as we discussed, with some questions. And so Dr. Wasserstein, I'm going to start with you. So once a condition is added to a state newborn screening panel, we can start to see the changes in the diversity of the disease population as a condition gets the benefit of having nationwide newborn screening. How can we use pilot studies to gain a better understanding of diversity of a disease population prior to addition to these state newborn screening panels?
Interesting question, Dylan. So, these in general, we screen for rare diseases. So you can't pick and choose who's going to have the disease. So you have to make sure that you're casting as wide a net as possible when you are implementing a screen. Screen Plus, which you mentioned before, is a pilot newborn screening program that we're conducting in New York. And we're evaluating how well we can screen for 14 additional disorders on top of our routine panel. And we've specifically chosen to cast this wide net by using pilot hospitals that are in really diverse communities in New York City. We're in New York City, so it's not too complicated to do. But the goal is to see how well we can screen, how accurate we can be. We're using multi-tier testing so that we can look at it from a few different angles, biochemical as well as genetic. And hopefully we'll also learn how common these diseases are in these populations. Most of the information that we have about these super rare disorders come from very specific populations that might have a geneticist in the community who can do those numbers and kind of get those disease incidence rates. So hopefully by our careful choice of these hospitals in these diverse communities, we can start at a running pace while we're implementing these disorders by getting that information about our diverse communities.
Great, thank you so much. And I want to follow up with a question for you as well as the other panelists. So you're discussing the importance of picking hospitals in diverse areas. You also highlighted that in New York City, that's a little easier. But what is some information that we can make sure that we should begin to start collecting? And so when we are in hospitals that, let's say, aren't as a diverse population, that we are still picking up those within all communities, even if it's in a kind of less diverse area. If that makes sense.
Well, it's also important. You get who you get in the area, right? So we can choose the hospitals. Sometimes if you are looking at, for example, a medical record, some people self-report what their ethnicity is. Sometimes it's accurate, sometimes it's only one choice, which is not really reflective of the American population. Many of us are from a few different backgrounds, and so that's often not the most accurate assessment. You can ask people what their self-reported identity is, and that's a way to collect it. What we're trying to do for Screen Plus is in order to make sure that when we approach people in our hospitals, even though the hospitals are in the right neighborhoods, we want to make sure that we're being as inclusive as we can. So we've translated all of our study documents into 9 different languages. All of our recruiters are bilingual, English and Spanish, because those are the most common languages that we have. But we don't want to miss anybody who speaks Albanian, for example. We want to make sure that we get them in. So we're doing feedback constantly. If people are not wanting to participate, we're trying to figure out why. Is it a language issue? Is it something that we're not doing that might, we want to make sure that we are as welcoming and inclusive and comprehensive as possible to everybody in those communities.
Wonderful, thank you. And I open this. Oh, perfect, Sarah, you've right unmuted yourself.
Yeah, thank you so much. And Dr. Wasserstein, I really appreciate hearing that you've translated the materials into so many different languages, because from our perspective where we work, not only translation, but health literacy is so key in kind of when you cast this net, making sure people understand the communication and can engage in it. And I think that's certainly an element that just emphasizes and addresses getting as many people to participate in the pilot studies as possible. The other comment that I wanted to make regarding kind of diversity and inclusion is this whole concept even beyond race and ethnicity. And what might be the other demographic features or factors that may have impact to these specific diseases. And I'm certainly not an expert, but different variables like the mother's age, social determinants of health, we know that that may have some impact, and whether those are also very relevant demographics that are collected. Thank you.
And I would add, Dylan, that for a patient advocacy group, the way that we reach out is by trying to make materials as culturally appropriate, translated, like Dr. Wasserman and Sarah were describing, so that our community, our patient community is as educated as possible about the disease, about newborn screening, about opportunities that provides to families. So I think as a patient, Cure SMA as a patient advocacy organization, we have a responsibility to our patient community, those affected by the particular disorder, to provide materials that are educationally appropriate, culturally appropriate, language appropriate, so that the community is as informed as possible.
Wonderful. Thank you. And I think building off this conversation, Sarah, I want to direct this next question to you. We've talked a lot, we've already started talking a lot about new questions that we would like to be adding in terms of demographics and such. But obviously there isn't just one giant newborn screening study. So my question to you is, like, what is the feasibility of adding new uniform questions across all studies to ensure that we are in fact collecting the same data so that we can work together with these different data sets?
Yeah, a great question. Thank you for that, Dylan. And I just also wanted to thank you and the rest of the panel for the opportunity to join this conversation. It's not an area I live in day to day at the MRCT Center, but it's been a really neat window into another area where really achieving, diversity and equity is super important. Just by background of kind of how I landed here, in August of 2020, the MRCT Center released Achieving Diversity, Inclusion, and Equity in Clinical Research, which is a 500-page comprehensive guidance document and toolkit that's really a culmination of a 3-year project at the center that we took on to tackle diversity in clinical research from an ethical, scientific, and practical standpoint. And when I thought about, when I think about this question, I want to just make a couple points related to collecting race and ethnicity data. So they are routinely studied in health disparities and health equity research. And over the past 18 months or so, there's been a lot of pressure in the clinical research industry to ensure inclusive and diverse patient populations, certainly brought to the spotlight from the COVID-19 vaccine research. Some people actually argue that race and ethnicity are generally social constructs and proxies for biological and or genetic differences, but at the same time, there have been these similar calls for uniform standards, and alignment and consistency have really yet to be achieved across the board. In federally funded research and research that's going to be submitted to the FDA for marketing applications, there are requirements that many of you may be familiar with for collecting and reporting race and ethnicity. And those are from the Office of Management and Budget, the OMB standards. These go back to 1997 for classification of federal data for race and ethnicity. And they serve as a starting point to define, minimum standards for collecting and reporting data. It's a two-part question. So first you ask the patient or the participant to select their ethnicity, either Hispanic or not Hispanic. And then the second question is about race, and the categories are white, Black, Asian, Native American, or other. Admittedly, these categories are not complete. Almost 25 years later, they may not be the most accurate categories if we're able to categorize ourselves at all. And different groups, including the Health and Human Services, have elaborated on these core categories, including some additional categories for Asian and Native American and others. They're certainly not perfect, and there are concerns that it maybe is not reflective, but it does provide a starting point for collecting race and ethnicity. So to more directly answer Dylan's question, I think the bottom line is that the feasibility and the reality of collecting uniform questions requires coordination, collaboration, and agreement. And I took some time to go back and look at the specific newborn screening collection forms in different states, the ones I could find. And the majority of them do ask a question. Sometimes it's titled race, sometimes it's titled ethnicity. And the choices are generally a modified OMB standard. It's one question instead of two, offering white, Black, Asian, Native American, other, and Hispanic. So kind of joining the OMB standard questions together. And the directions say, mark the appropriate box for race. I think this kind of raises questions for me, as I'm sure it may raise questions for other people. Most importantly, who's documenting this? Ethnicity and race should really be self-reported. It's really hard to tell the ethnicity and race of someone just by sight. And so that's an important question that we should think about as we start creating and collecting these uniform standards. And I found interesting too that it asked for one race. It didn't take into consideration mom or dad, and whether there is some consideration somewhere along the lines when we start thinking about these rare diseases, and how to determine the baby's race on these forms. I talked a little bit about in maybe other relevant, important demographics. And I would love to hear from Dr. Wasserstein on whether, when she's really getting into collecting genetic testing and some of the more biological markers, are those more important than having someone report race and ethnicity? So again, bottom line, it's feasible. I hope it's realistic. It's going to take work. It's really important that race and ethnicity, if tracked, is by self-identification. And I think it's really important to think through, what are you going to do with the data? Like we just heard, it's one thing to screen. Screening in the US is inclusive, but it's really what happens after that, and the education and the communication and the accessibility to diagnosis, treatment, and follow-up. So thanks so much. I'll stop there.
Thank you so much for such a wonderful answer. And I'm gonna not get in the way. Dr. Wasserstein, if you want to kind of respond to that last question from Ms. White, that would be a great place to start.
So it's an interesting question, Sarah, and something we were trying to work with. We were trying to collect the data on so let me back up. We're enrolling 175,000 babies. So we're not asking, when we're enrolling people, we're not asking them what, how they, what they perceive their race or ethnicity to be. We did a similar pilot screen a few years ago, and we were actually collecting the data that was on the newborn screening cards that you just mentioned, which is like one choice. It's not accurate, and we realized it wasn't adding anything, or it wasn't accurate enough to make any conclusions based off of that information. And now back to Screen Plus, where we're enrolling 175,000 babies, and it's just too onerous to ask them, every baby that's being enrolled, or every family that's being enrolled, what they would want us to write down. So we're collecting that data only on those babies who are either screen positive or who have uncertain disease status. We'll also have the genetic information relevant to that disease. So if there are variants of uncertain significance that haven't been seen before, in a Haitian child with metachromatic leukodystrophy, we'll have information about that. I wish we could get more, but I think, like you said, there are definitely some holes and gaps in the way it is available in the electronic medical records right now.
If I could just quickly respond, I think that's so smart, because if you're enrolling thousands and thousands, hundreds of thousands of babies, you don't necessarily need the ethnicity and demographics until you need it, and it sounds like at the point of need, you can get it, but also looking at maybe more importantly, those the genetic features and biological markers, and then using that as a means of really identifying who these babies are.
Thank you guys for that. And Dr. Wasserstein, I wanted to build off a point that Sarah made a comment about in terms of the FDA and NIH OMB requirements. And so as a fairly funded researcher, I'm curious in terms of your experiences, and based on those, how realistic do you think it is to ask additional federal researchers to, I guess, improve on those OMB standards? And so you've talked about how in Screen Plus that you guys kind of go, it sounds like you go above and beyond the OMB requirements. But curious if you think that is something that, going back to hoping that we get some actual fundamental steps forward, is that something that we should be advocating for to the FDA and NIH to expand those OMB requirements from the 90s?
I think, just my opinion here, I think that part of the reason why they haven't been expanded yet is just because it's just so complicated to do so. How do you define, how do you report what's accurate, what's not accurate? Is it the ultimately the genetic information do we really want to do that? Yeah, it would help with some data, but it also opens up a whole can of worms that makes things a little challenging. How are we defining race? How are we defining ethnicity? Is it medically relevant sometimes, but often not? So it's a tough question, and I think it hasn't been answered yet because it's just so complex.
That's fantastic. I mean, thank you for the honest answer. I mean, I think that's what we're looking for, because this is a complex issue. And so, as I said in the beginning, I feel like we're going to come out with as many questions as we started, but hopefully they're a little different and a little more nuanced. And so I think this is a great example of that, is how do we deal with the complexity of it in determining the medical relevancy. And Dr. Schroth, I saw that you unmuted yourself, so I will stop talking.
I just wanted to throw something out there. I mean, I think we've thought about race and ethnicity, and I know my co-panelists here are having the same thoughts. We're talking about it as if it fits into one box. And instead of, identify or check the box that fits you best, it's really choose all that apply are really where we're at in this country. And we haven't changed our thinking around the collection of ethnicity and race to match what's actually happening across the US, which is, we just are so diverse. I mean, very few people fit into one basket, which I think just complements what Dr. Wasserstein and Sarah White are saying, but it's how do we tackle that piece? So I'm just going to throw it out there. One of the questions that we're not going to be able to answer today, but I think we're all thinking it.
You have actually set me up quite nicely for a question that I wanted to come to you about. And so you are going to try and kind of answer the question that you just asked yourself, which is, as QRSMA does run patient registry, and a fantastic one at that, how can patient advocacy organizations get involved in that? And how can they use their patient registries to ensure that they are truly representing the diverse patient population?
It's a fabulous question, and similar to what we've heard before. I mean, we get what we get in a sense. I mean, for us, it's outreach to be as inclusive as possible across our community, and finding other ways. I mean, to reach people. I mean, sort of gold standard is having website information available, and then email. But we're also doing more social media outreach. And using our connections to reach more families, to include them in the newborn screening registry that we have, which is patient entered information for us. And we're also going through our providers that we have relationships with across the country. So those clinics that are caring for individuals with SMA, reaching out to them saying, hey, if you've got patients that fit this criteria, please have them contact us. So it's really doing this wide sweep of trying to reach people in the ways that make sense to them and resonates with them. So we're in sort of the same boat, identifying families and individuals with SMA, trying to think of every possible resource we can to reach them. So I didn't answer your question, Dylan, but I'm just throwing it out.
No, that's fantastic. And I think that kind of leads into a little bit of a question that has been posted. And And I know Natasha began to answer it, but I still want to post it to the full group because I'd be curious to hear about everyone's opinion on this. Does newborn screening currently provide for education for those who may not test positive for disease but are carriers? And so I wanted to start there. Natasha's answer was yes, families do get information on trait status. The issue is that it is a piece that needs to be brought back up in the child's care, maybe in the teenage years, so they know going forward. But I kind of want to take that question and expand to talk about trait status, because that is something that within the newborn screening population, I think is a growing question, trait status, as well as phenotype of your condition. And so how would you guys discuss approaching situations like that where it's not, we'll call it the classic newborn screening standard, where it's you get a positive newborn screening, confirm, and you begin testing right away? How do you approach this question for individuals where they're going to be needing this information maybe farther down the line?
I'll take a stab at that one. So, I think that the traditional focus of newborn screening has been on direct benefit to the baby. We're going to find a disorder that we can treat, we can intervene, and we can change the outcome for that baby. I think we're in 2021, and it's time to start rethinking what those benefits might look like. Not clearly, we still need to benefit that baby, but are there other benefits external to the baby, like identifying if the baby is a carrier? Because that might have implications for the family. Would they want to know, are there ability to use that information to make reproductive purposes? Are there other people in the family who might be at risk? So I think in terms of identifying traits, right now it's challenging in newborn screening because a lot of newborn screening is biochemical based. So we might not be able to pick up carriers. As we're moving towards more genomic based newborn screening, we will have that information. How do we have the people power to interpret it and share it, and then to do all the appropriate genetic counseling is a huge open question that is unresolved and complex, just like everything that we've been discussing today. But I do think that it is the future. I think that we will have that information, and we're going to have to figure out how we're going to share it so that we can, again, expand those benefits.
Yeah, if I could just add on to what Dr. Wasserstein was saying, in the clinical research space, there's similar debates about return of research results, right? And I understand this is clinical data, but there's always these questions about, in this case, what can the carrier do about this information, either now or in the future? Is it the parent that is consenting to getting the data? When do you tell the child? How do you tell the child? Who, as Dr. Wasserstein was saying, is it the pediatrician's responsibility, since they're the primary clinician for the child into the teenage years? Is it their responsibility, or is their action taken ahead of time? So I agree, it's a complex set of decisions to really think through what happens when you return, carrier status to a baby or the baby's parents.
Great, thank you. And there's another question that came through. And I kind of want to take that question and build upon it in terms of, we'll call it distrust in the community. So obviously when working with some of these populations, there is a history of issues when interacting with the medical population. So as 3 individuals who on a daily basis work on interacting with these communities, what are some best practices as well as some aspects that need to be kept in mind when working to rebuild the trust with communities that have lost trust with the medical community over many decades and generations? Again, my apologies for a very big question that I know nobody has a direct answer for, but I'm hoping that's what we're here today for.
Yeah, I'm happy to at least take the first crack at it. Distrust is a huge issue, obviously in clinical care, obviously in research. Some of the work that the MRCT Center has really tried to focus on is thinking about, how do you educate and engage with communities, and you're engaging with people not just by walking into their community, but someone mentioned in here church communities and you're engaging with people where they go, and what is important to them in their community. And they also want to see people like them. And so really thinking about opportunities in the medical field that really mentor lots of different underrepresented groups, you know, to kind of be a vocal piece, to be involved in medicine, to really help with that engagement. And I think you have to have engagement before you can even get to trust.
I totally agree with you, Sarah. You have to meet communities where they're at. And trust is something that's earned over time with activities and doing things with the community that is clearly beneficial to them versus being taken advantage of, which is I think most often the reason why distrust occurs is there's a perception of taking advantage without getting value back. So it's, you know, it's time. It's how does newborn, and I think for some communities, and specific to our question, which is how does newborn screening benefit the communities, and how are we sharing back information? And we just need to think really carefully about that.
I think that what you both have said has been spot on, and I agree with everything you've said. I think another piece is to ensure that you have engagement and get feedback from people. What are we missing? We're being, you know, we think we're being transparent and sharing as much information as we can, in as many languages as we can, but are we missing something that is hampering your ability to trust us? And what is that, and how can we fix it? We're having feedback. We have surveys that we're asking throughout our study. We're having some qualitative interviews, and I'm hoping we can gather this data so that if we are not reaching people because of mistrust, they'll help us at least to give that little feedback, and then we will obviously take that and incorporate it. It's challenging.
And it's a continuous process to work on. You know, you can't, it's not like you earn trust once and you have it forever. It's a continuous feedback loop in a lot of ways. You know, engagement, getting the feedback, and then taking action based on that feedback.
Thank you all for such wonderful answers. And I think when talking about that, I think it also, when talking about newborn screening, I think it also helps to remember in theory, newborn screening provides the opportunity to be in contact with these communities from day one. And I think that's in terms of that continued engagement, making sure that it is not just give the diagnosis and move you on your way, to continue that engagement going forward and recognize that you have just given them a life-changing diagnosis. Maybe checking back in every now and then is the worst thing in the world.
Yeah, Dylan, if I could just add to that, I think the communication begins during the prenatal time, you know, and really letting every community know this screening is done in the, you know, in this state, or, you know, talk about the US, talk about the state, like really make sure that different communities know what the screening is, why it's being done, and what happens if. I'll be honest, and maybe just, you know, it's one of those things when you're having a baby. I don't remember anything about newborn screening when I had my kids. I don't know how many other women remember it as well, but I certainly was not asked the race of my children. And so, you know, I think doing that education, you know, before the parent or parents are in this massively intense moment, I think is really important.
Yes, and I can not comment, but I can speak for when I've spoken to people about it. Nobody seems to remember their child going through newborn screening, so you are definitely not alone in that. Again, I do want to continue to encourage people to put their questions in the chat box. So thank you so much for everybody continuing to put their questions in. But as I wait for additionals to come in, I still have a whole bunch. So again, I will defer to the questions in the chat box first, but without them, I will go back here. And I wanted to pose this question to the entire panel, but Sarah, I was hoping you could start with this. we're talking about issues that impact the entire public health system. These are not issues that are unique to newborn screening. They are not unique to newborn screening pilot studies. These are across federally funded research across the entire public health system. So what are some ways that we can work towards that, knowing that we're just one part of the public health system trying to change an issue that is across the entire board?
Yeah, that's a big question. I think I would start with the importance of access, engagement, and knowledge, and really seeing those three different concepts as, this whole idea of you need to provide people access, whether it's to clinical care or whether it's to research. You need to engage with them to make sure that they really understand what either the medicine, the science, the research is about, and what benefit it is to them, what they can learn as we are learning. And then really needing to provide them continued knowledge. Again, when we think about research, there's been so much pressure on the research enterprise to really improve diversity and inclusion, not only in the US, but when you think globally, because you're really thinking about medicines that could potentially, and some do, have a different effect on different, and I hate to use race and ethnicities because they can really be these social constructs, but there are particular medicines that are impacted just by differences in metabolism or different enzymes or whatnot. So I think, again, going back to this whole idea of access, education, and knowledge, and really speaking to people, meeting them where they're at, is a way to move forward.
I've been looking through the chats, and I think that there are some amazing points that have been raised in terms of, we've been focused on newborn screening and making, trying to ensure that everybody has equal access to it, and that we're representing as much of the United States as we can, and who we screen and choices. But it's access to care and ensuring that everybody has that same access after the screen is done, and then that continues. And evaluating, are there groups that we're missing that are falling behind? And why is that, and what do we do to make that better? It's not just the screen, it's the whole process. And it definitely, obviously, is an ongoing issue that's been ongoing for decades in the United States, and we need to address it. I'm glad we're talking about it. I'm hoping that, all of the efforts that are being made across the globe to try to address some of these inequities are fruitful. Newborn screening is a piece of it, an important piece because it starts at birth, but it's much huger than what we're just talking about.
Can I just bring up a point that is in the chat from Natasha about really, it's not just how the patient perceives the healthcare community, but it's about the healthcare worker perceiving the patient. A very real issue. And I think on the research end of things, we're really advocating and developing trainings in diversity, inclusion, and equity that include things like cultural competence and bias, and really making sure the medical worker, in this case, the investigators and the study teams, are really aware if they have bias or how to speak to someone in a way that is acceptable to their culture and that they will understand. And I think that is such a strong point that we all need to remember. So thanks for bringing it up in the chat.
And it extends to clinical care. It's, are we seeing differences in time to treatment? And we're looking at that in the SMA community overall, because we have right now very few babies, but 200 to 300 infants have been identified with SMA by newborn screening to date. And we're trying to capture that data. Is there differences between time to treatment? And how do we improve that access? Because specific to SMA, but this is across other conditions, is that the treatment itself is incredibly expensive and can be difficult to access because of prior authorization requirements that the clinicians need to complete and are able to do it more efficient. Some are able to do it more efficiently than others, depending on their local resources. So I mean, there's just a lot to it. And I totally agree. NBS, newborn screening, is the beginning of what really needs to happen from a public health perspective. How do we can identify that they have a horrible disease, but then getting access to the care, to the medications, to the treatments that ultimately make their lives different is so critical.
Great, thank you. And actually, Mary, I'm going to come right back to you with an additional question. So going back a little bit into some of the nitty-gritty of the data collection itself. Obviously, with SMA having recently been added to the RUS about 3 years ago, you've seen the data collection change from when you were on minimal state panels to many state panels. Not all 50, which is where it needs to be, I can say that, but you guys are getting close. And so how have you seen the data collection change kind of pre and post, specifically to the types of data that we're talking about today? And what are some areas that have been made easier with the addition to state panels that you had hoped you could have had that information prior to the addition to state panels?
Well, that's a great question, Dylan. So we're at 38 out of 50 states, and that represents 85% of babies being screened for possible SMA. My sense is we're still in the early stages of collecting data, even though we're 3 years post-RUS. Just understanding who the patient community that's been identified is. I can share with you that, and I'll just admit this, is that we actually didn't ask about ethnicity and race, and we're doing a revision right now to collect that data on our population. I'm embarrassed to say that out loud to y'all, but hey, it is one thing that we didn't collect. And now we're thinking very carefully about how will we collect it, because it's complex, as everyone has identified. But we need to have that information to better understand the impact of this disease on across the U.S. I mean, is there a race difference? And based on other early data, no. The answer is no, but we want to know about that. So we've asked all the questions about treatment access and questions about symptoms at time of birth and those sorts of things. And then we're doing longitudinal follow-up. There was a key piece we left out, but we're correcting that now.
Actually, I'm going to follow up on that point you just made in terms of you're kind of working through the questions now on how best to collect it. And so I think, again, that's kind of what we're talking about. So whatever you can or are willing to share, I would love some insight in that process. And what are the conversations that you as a foundation are having right now in terms of how you want to go back and collect that data?
I'm not sure. Ask me again. I'm sorry. I'm not sure I totally captured what you're asking me, Dylan.
Yes. So as you said, you guys are going back to gather this data, and you made a comment about how that's something that you guys are kind of working through at the moment on how best to go about that. And I think that really gets to the core of today's panel. And so I'd be hoping, and again, if it's internal, I fully understand this is a question we had not planned, so you're a little on the spot at the moment. But I would love, if you're okay, to provide a little bit of insight in some of those conversations that Cure SMA was having. Once the decision was made to go back and gather that data, what were the questions and what were the issues that you guys were considering when developing the questions, the data, the type of data you wanted to ask? And so kind of walk us through some of that process of going back to collect that information.
Well, let me start at the beginning, which was we actually developed our survey by gathering key opinion leaders, clinicians, and researchers within the SMA community and asked them what were the important questions. And we probably could have asked 50 or more questions, and we whittled it down to 20 core questions, which involve understanding symptoms at time of birth, access to treatment, things that the babies are potentially needing, and then to collect that data longitudinally. And as I said, we had left out the ethnicity. I think part of what we're looking at now is is the phraseology, the way that the questions are being asked, clear? Because we've gotten some answers that don't quite make sense to us. So we're just going back and doing some revisions about what we're asking, because it's possible that people just aren't understanding the question itself. So it's things like that. And providing for those that are, check a box, that we offer people the option not to answer.
Great, thank you, and thank you for kind of let us into your decision-making process a little bit. There's a question that came through the chat that I want to make sure that I pulled out. Does anyone have data on differential uptake by ethnicity, ancestry, or SES when pilots have been added to an existing newborn screening panel that require explicit consent in a state where explicit consent was not required before? The answer is no, that's fine. I do not know of any, but I just wanted to make sure I pulled the question in case someone did.
So like I had mentioned before, we did a previous pilot screen specifically for lysosomal storage disorders. And we enrolled about 65,000 babies over a 5-year period. So we did get consent. We don't have explicit differential uptake by ethnicity, ancestry, or socioeconomic status, Robert, but we did have about an overall 73% consent rate, and that was again in similar hospitals to what we're using right now. So we had these diverse populations. We had good uptake generally, but again, we weren't collecting specific information from those families. We tried based on what was reported, like I mentioned before, but it's probably not that accurate. But there was no overt changes in acceptance or agreement to participate based on what we saw.
Melissa, just as a follow-up, why do you think you were so successful in getting diversity there? I believe you, of course, but I find that incredible.
Well, it was, I think, choice of hospital. For example, our hospitals now in Montefiore, I think that, we're participating in some other studies where we are collecting much more precise information about background, and we're between 60 and 80% underrepresented populations at our hospital. So it wasn't that we were specifically looking to recruit from those populations. That's just where we are. So I don't think I can't say that it's anything special that we did. It's just where we are. It's just kind of luck of location.
Thank you for that wonderful answer. I'm just trying to make sure I sort through the chat. To Natasha's point, to AJ's question about, is there any talk of automatic pathways to Medicare for babies who are diagnosed so that lifelong follow-up care is possible? I want to echo Natasha's point that I'm not aware of any specific conversations, but curious if anybody on any of our panelists are aware of any conversations around that. If not, that's...
Yeah, so I'm also a pediatric pulmonologist, and access to Medicaid is state dependent, and sometimes a bit tricky. Sometimes families can qualify for a waiver program to get access to some of the resources, but there are a lot of stipulations, and the bar has been set higher and higher for who qualifies for Medicaid in the criteria. But I'm not aware of nationwide, because it's state by state for access to Medicaid. Infants generally don't have access to Medicare unless they have underlying chronic kidney disease.
Great, thank you so much. And again, I want to encourage everybody to, if they have any questions, please put in the chat. We are getting close to being done. I do have one more question, but If anybody has any additional questions, please do feel free to drop in the chat box. If we can't answer them now, if we run out of time, we will make sure to follow back up. But again, this question is for all panelists, so whoever wants to answer, please feel free to jump in first. As many are aware, newborn screening is very much a state-based program. And so that is the first interaction that these families are having are with the state. And so I'm curious about kind of what is the role of state newborn screening programs in this effort, and how can outside organizations such as patient advocacy organizations, researchers, or industry, what role can they play in working with those state programs and essentially approaching them properly to start addressing this question as well? Another way to rephrase this question would be, based on your experiences working with state newborn screening programs, what has been some areas that you have found they're amenable to talking about this issue, or amenable to adjusting how they work on this issue to make the updates that we've been discussing today?
It's state by state. Curious MA has worked with many of the state labs as we've been advocating for implementation of SMA. And every state has, I hate to do this. I feel like I'm defending the states, and that's really not the position I want to take. But we've encountered, varying issues depending on, it's dependent on their legislatures, dependent on the resources. COVID has had a significant impact on what state labs have been able to do in other areas, not related to COVID specifically. I think there's some advantages to looking at the issues from a federal level, although related to newborn screening, it's federal recommendations, and each state implements and does the work as they see fit. Although the APHL is a very strong group, and they do a lot of collaboration across states to do their work. Curious MA has also been involved with projects supporting other researchers looking at newborn screening related to SMA, and they've encountered variability in interest in participating at various levels, again, often due to resources. But I think there's opportunity. There's opportunity here to try to make this more efficient. And for state labs, the issues really are around resources. So are there ways that they benefit? Can we collaborate with them so that we all win? And that's the question I would put back.
Can I ask Dr. Strauth maybe a naive question in this panel? When you apply to get SMA on the newborn screening panels, are you doing 50 applications?
No.
One for each state?
No.
Oh, it is coordinated. Okay. Okay.
No, so it goes through the RUS, and it's totally fine. We submit all of our materials to the recommended uniform screening panel at the federal level, and then it goes to the committee for review, and then HHS secretary signs off. But that's a recommendation. Some states have legislated that they have to implement within a certain period of time after adding to the RUS, like California, it's 2 years. And I apologize, I know there are other states that also have that legislation in place. That is the exception, that's not the norm, but that would be great if there were more of those. But then it's up to each state to decide how they're going to implement it. Each state determines the assay that they're going to use. They don't use, one assay across all the states, which I sort of blew my mind, because it seems like it'd be more efficient if everyone did the same thing. But yeah, so that's something that I have a limited understanding of. But every state has their own rules about implementation. Some it has to go through the legislature, some it has to go through other bodies. So, and Dylan, fill in if I'm not explaining this in my 2-minute summary of our experience.
No, I think that was fantastic. We had it in the past, and we could do it again. We've talked hours about this, and so I think in a 2-minute span, that's the best way to go about it. I do want to take a break right here to first and foremost thank our panelists for their wonderful participation today. I personally enjoyed the conversation thoroughly, and there's a lot I think that came out of this. Before we do break, I do want to pose a question to the panelists, and it's just a quick, is there anything that you think we missed? Is there anything that you want to make sure is flagged, or anything that you want to highlight from today's discussion that you thought was really important that you want to make sure to highlight for our attendees today? If the answer is no, that's completely fine.
I'm going to start to give the other panelists this moment. I just thought this was a great opportunity, and I really want to thank the organizers for inviting us to have this panel. As the audience heard, there's so much that could be done, and it really takes a coordinated, collaborative effort to really move the needle forward. And this is all about making it better for our children. You know, it's those children who have these rare disorders who benefit the most from newborn screening and the work that we're doing. So thank you. Thank you for attending.
I would just add that, you know, maybe some important points to hammer home are this coordination and agreement in collecting data. And I think just, you know, really going back to the importance, if we are collecting race and ethnicity, that somehow you figure out how to self-report and really get the self-identification from the family that you're collecting the data on, and just thirdly, the importance of access and engagement with all of the communities.
I don't have much to add. I mean, we're talking about, you know, from academic medical institutions and patient advocacy groups. We're not hearing from families engaged in newborn screening in this discussion. So maybe next time around we can include some people, you know, from all different kinds of backgrounds to participate in this discussion and see if we forgot something obvious that maybe they could help to ensure that we do get that equity that we're all looking for.
That is, I think, a fantastic point to end on, because this is, again, an issue that we want to continue talking about. We do not want to just kind of be a one-stop shop. So I think that is a great point and something that we can definitely continue to build on moving forward. And if we're saying, again, thank you so much to our panelists for their participation today and for their wonderful insight. Thank you to all of you for attending and for your wonderful questions.